I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Welcome to the March 12, 2025 regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Cheryl, would you please take the roll?
Yes. Director Wallace.
Present.
Director Nicholson.
Present.
Director Yee.
Present.
Director Stewart.
Present.
Director Epen.
Present. Thank you. We will now move on to our communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes. On issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Seeing none, we'll move on. Cheryl, are there any written communications?
There are no written communications.
Thank you, Dennis. We will now move to the consent calendar. The consent calendar consists of those items, agenda items, that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Okay. Does any member of the public want to remove an agenda item from the consent calendar? May I have a motion to approve consent calendar item A?
I move that the Board of Directors approve the consent calendar item A.
Thank you.
Second.
Thank you.
Okay.
Cheryl,
thank you.
please.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Yee.
Aye.
Director Stewart.
Aye.
Director Epen.
Aye.
Thank you. Okay. We're going to move into our presentation.
Yes, thank you, Director Wallace. This evening we're going to have the presentation that we postponed from last month, CT surgery and structural heart program. This evening we have two presenters, Dr. Ramin Beghi, and I'll give you a bio on him, and then also Larry Labossiere, our Vice President and Chief Operating Officer. So the two of them are going to present. Dr. Agarwal was not able to be here this evening. So just to begin, Dr. Beghi can currently join UCSF School of Medicine faculty in the Division of Cardiothoracic Surgery and assume the position of Medical Director of Cardiothoracic Surgery at Washington Hospital since May of 2016. Dr. Beghi has practiced cardiac, thoracic, and vascular surgery for the past 22 years at UCLA, Stanford University, and UCSF medical centers, and has been practicing the entire scope of his experience and expertise. He has served as the Director of Thoracic Aortic Aneurysm at UCLA and the Surgical Director of Lung and Heart-Lung Transplantation at Stanford University Medical Center and Lucile Packard Children's Hospital. As Medical Director, Dr. Beghi assisted with the development of a full range of cardiothoracic services locally to meet the needs of our community. To further that goal, Washington Hospital has a strategic relationship with UCSF Health and UCSF Benioff Children's Hospitals. And then I just will give a quick overview of Larry Labossiere. Has been with Washington Health since June 2021. He began his career here at Washington Health as the Vice President and Chief Nursing Officer in June of 2021, and then was promoted to Vice President and Chief Operating Officer in 2023. Larry received his BSN from James Madison University in Harrisburg, Virginia, an MBA from National University in San Diego, and his MSN from UCSF, and is a certified emergency nurse. Larry spent over 20 years in various nursing positions in the military at naval hospitals, followed by 3 years in 2016 as the Chief Nursing Officer at Palomar Medical Center, Poway, in San Diego, also a healthcare district. So Larry, I will turn it over to you to
Yes.
begin with.
Thank you, Kimberly, and I'll just say a few words, and I'll turn it over to Dr. Beggy, who's going to do the majority of the presentation tonight. But I just want to give a little history, and I know Kimberly's mentioned that Dr. Beggy came here in 2016, so he's on his 9th year at Washington here. Thank you, Dr. Beggy. And a year after him, as you'll hear in the presentation, came Dr. Tang Li, and we expanded our CT surgery program. And then a few years later, Dr. Harsh Agrawal came over, and we started doing TAVR procedures here in 2020. So we've been doing that for about 5 years. We hit a milestone this past year of our 100th TAVR procedure, which was very exciting. I want to tell you about a little bit about some of the growth that's gone on with our TAVR program and structural heart program in general. Just from a reference standpoint, it took us from 2020 to 2024 to get to 100 cases over here. This fiscal year, between July 1st and June 30th, we're going to have done over 100 structural heart procedures this fiscal year. And that's a combination of TAVR procedures, and as you'll hear, the new Watchman procedure that we started doing here. And then we're going to be moving forward in just a few weeks here with our first MitraClip procedure. So we're very excited to be expanding the services we can offer to our community. And as you likely know, it takes many different people from all over the healthcare system to make sure this program is going the way that it needs to be going. I see members of the marketing team on the call, of strategy. We've got our clinic leaders. I see Melissa's on the call today. And we've had to do a lot of training with our nurses in the cath lab and the operating rooms. We've got very skilled nurses in our emergency department, and then obviously in our inpatient areas in the ICU and the telemetry department, where we're now housing a lot of our TAVR patients. They're coming directly from TAVR. They used to go to the ICU, and now they're going directly to the telemetry department after they've had their TAVR procedure. They're getting great care there. I just want to thank Dr. Beggy, Dr. Tang Li, and Dr. Harsh Agrawal, who's not here tonight. I know Linda Antes has been 30 years here. She's been helping us develop and coordinate this program. So she's obviously been a huge part of this, as has Alvin in his cath lab role and the OR leadership. There's been a lot of ongoing training as we continue to bring on new procedures. And I'll turn it over to you, Dr. Beggy, because I know that you've got a lot of information to share with us about what's going on with our CT surgery program and some of the advancements we're making with structural heart.
Thank you very much, Ms. Hart. Thank you, Mr. Lavoisia. Thank you, the board members, for inviting me to be, and I do apologize for my not being able to meet you on February 12th. I'll have a few slides that I will share with the board members. I'm sorry, I guess I won't be able to advance it. Next slide, please. So a little bit about we'll talk a little bit about the history of cardiothoracic surgery at Washington Hospital and Washington Health. I'm actually relatively familiar with that since my residency at Stanford. I will introduce our team. I'll describe briefly the conditions that we treat on the cardiovascular side, and then our plans for the program expansion. On the structural heart, I will discuss primarily what my collaboration and role has been working with Dr. Harsh Agrawal and colleagues. So Washington Hospital actually opened in 1958. At that time, I had only 150 beds and served the community of about 18,000 people. I knew the late Dr. Robert Pipkin when I was a general surgery and vascular surgery fellow at Stanford. He was also operating at Stanford. In 1986, not too long after the Stanford program, he started operating at Washington Hospital as the founder of a cardiothoracic surgery program. In 2016, when I joined UCSF, the important part and perhaps the integral part of my appointment at UCSF as a faculty member was to be the medical director at Washington Hospital. This endeavor started in 2016, and in 2017, we recruited Dr. Tang Li to also join us. So the two of us have been the two cardiac surgeons. Later on, in 2024, Dr. Arthur Hill, who is also a senior cardiac surgeon at UCSF, also joined our group to be able to help us with the trauma structural heart programs and trauma cases when there is necessary. In 2025, by 2025, we have performed thousands of cardiothoracic surgeons cases at Washington Hospital, which started with Dr. Bob Pipkin in 1986. Now we have 415 beds, and our community is over 400,000 people, and we continue to serve the community. And that's very important as I describe the kind of procedures that we're trying to do at Washington Hospital in the vicinity of our larger community that is expanding. Next slide, please. So here's the picture of the three of us, Dr. Arthur Hill, Dr. Tang Li, and myself. There's a picture of us operating at Washington Hospital with one of our cardiothoracic surgery fellows, and I'll describe that also in the future, in the next couple of slides. May I have the next slide, please? So the conditions that we treat is, as Ms. Hart said in her kind introduction, we treat all sorts of cardiovascular diseases. Coronary disease is the mainstay of our practice. Majority of our patients are urgent or emergent when they get admitted to Washington Hospital after cardiac catheterization. Over about 3/4 of them are urgent and they need to be operated on within the same hospitalization. We treat the aortic valve and mitral valve, tricuspid valve, and pulmonic valve, which is a valvular heart disease. The aortic valve has had a significant change in our scope and our practice with the advent of transcatheter aortic valve. That I will describe that a little bit later when I talk about the structural heart program. We also do open and endovascular procedures for aortic aneurysms and dissections. We also started treating atrial fibrillation and arrhythmias with the surgical procedures. And that also has an impact on the structural heart program and the Watchman procedure that we'll describe a little bit later. We treat atrioventricular septal congenital heart diseases, abnormalities of the pulmonary arteries. So with the exception of a heart transplantation and the ventricular assist devices that we use with our collaboration with UCSF, we do all sorts of cardiovascular procedures at Washington Hospital. So for all of these cases that I'm going to describe, our patient populations don't need to go farther than their own community to have the procedures done. And if the patient does have end-stage heart disease or lung disease and they would benefit from heart transplantation, at least evaluation for heart transplantation, then we can expedite the transfer of those patients to UCSF through our connections with the UCSF Medical Center. May I have the next slide, please? I would just share with you the results of our coronary bypass grafting in 2023 and 2024. Coronary bypass grafting is a very common operation and is the most common operation at Washington Hospital when cardiothoracic surgery is done. This operation is very important, and there's a state of California through the California CABG outcome tracks the morbidity and mortality of coronary bypass grafting. We also share our data with the Society of Thoracic Surgeons, SDS, and then we'll get a report card back on how our patients are doing. I'm just delighted to express that in 2023 and 2024, we had no hospital mortality and no operative mortality for any of our coronary bypass cases. There was one case of a sternal wound infection in 2023, and then there were one case of renal insufficiency, renal failure in 2024. Renal failure is defined as if the kidney function, the creatinine elevates by the factor of 2, or if the patient temporarily requires dialysis. Other than that, our results are outstanding, and the deep sternal wound infection in 2024 has been 0%, and our major complications in 2023 was 6.25%, which is below the SDS and the like hospitals, and in 2024 we did a bit better at 5.5%. So we have continued to do these operations that I described with a very favorable results and outcome for our patients. If I could have the next set of data, please. So what makes our program special, different, and perhaps similar to major academic medical centers or other big hospitals, the fact that we have a 24/7 intensivist who stay in the ICU. They have 2 intensivists 24/7. So if our patients who undergo cardiothoracic cases get admitted to the ICU, the great majority they do, 98, 99% of them they do. They're taken care of by intensivists. If they have no surgical procedures, they get extubated, they get out of bed, and they are managed for various arrhythmias and so on, and then they transfer out of the ICU the moment they are stable. We have cardiac anesthesiologists who are trained in cardiac anesthesia. They perform transesophageal echocardiogram in the operating room. They are very facile with the management of the patients in the operating room, on cardiopulmonary bypass, before cardiopulmonary bypass, and after cardiopulmonary bypass. So this is sort of our discussion with our patient, is that they would get intensivist and a cardiac anesthesiologist. Our operating room is dedicated to the cardiac care. The nurses and the staff who take care of our cardiac care are specialized in that care, and they continue to take care of them. If the patients are healthier, like the TAVR patients, and they stay in the ICU overnight, great. But if the patients are also sicker and require renal replacement therapy or intra-aortic balloon pump, or they have a poor ventricular function, they're also very comfortable taking care of those patients. As I mentioned, about 3 years ago, the Residency Review Committee approved the extension of the UCSF Cardiothoracic Surgery Fellowship to Washington Hospital. This has sort of a dual role. It allows our residents and fellows to see how cardiothoracic surgery is being done in a non-academic but the regional medical center, which does the same kind of operations as they are performed in academic medical center, and also is basically a credit to us that we have a program that the residency review committee considers worthwhile for the training and education of our fellows. These fellows are postgraduate years 6 or higher. That means they have been out of medical school for 6 years. They have done general surgery, and they're in their first or second year of fellowship. So they are board certified or board eligible in general surgery, and they're doing part of the cardiothoracic surgery with us. So they also contribute to the care of our patients and management of our patients. So we have additional trained physicians who would take care of our patients. The trauma service started about over a year ago, and our support of the trauma service is primarily for the thoracic trauma and aortic trauma and cardiac trauma. So presence of our fellows is also very helpful in that, as well as the addition of Dr. Art Hill, who served at San Francisco General Hospital as a medical director and has a lot of experience with cardiothoracic trauma or trauma in general. We are on track to have our first cardiovascular hybrid operating room in 2026. Currently, our cardiothoracic surgery operating room has been converted to a hybrid room, a de facto hybrid room with a state-of-the-art fluoroscopy machine and anesthesia machine, that is anesthesiologists that are there, and also cardiopulmonary bypass. But in 2026, we'll have a designated hybrid room that would also allow us to do more procedures. May I have the next slide, please? And I'm sorry if I'm speaking too fast or my talk is too mundane. Please go ahead and interrupt me. I'll be happy to answer any question if something is not clear. So I'm talking a little bit about the structural heart program. So majority of the cases, this is basically would have been a talk for Dr. Harsh Agrawal, but I'm also close with him and closely collaborating with him. The structural heart program allows the procedures that would normally within the realm of cardiothoracic surgery can be done differently. Normally, cardiothoracic surgery involves taking the patient to the operating room, general anesthesia, opening the chest, and then performing the operation on cardiopulmonary bypass or the heart-lung machine where the heart stops. But over years, we have decided, or we have at Washington also, we decided that we need to bring this new technology to Washington Hospital as well. So not only coronary arteries can be treated without open chest, open heart operation. Also, the valve can be treated with the open heart, without open heart and open chest operation, and we can be done in a quicker amount of time, and the patient can stay hospital in a shorter amount of time and then be discharged from the hospital sooner than they would otherwise. So we are performing this operation in conjunction with the procedures that I described at Washington Hospital. We, again, over the past 12 years, we have learned that we can replace the aortic valve operation through a small puncture in the artery in the groin and replace it in majority of the patient with aortic stenosis. And those patients in general do extremely well and can leave the hospital sooner and return to their work faster. Maybe I can have the next slide, please. So what kind of procedures were normally done with open heart operation? Now we can do them with the structural heart or the transcatheter procedures. Closure of the atrial septal defect or the patent foramen ovale is one operation. If the individual is born with the defect within the atrium, then through a femoral or transcatheter access, we can close those defects. In the past, we'll take the patient again to the operating room and open the heart and repair it. Sometimes we still need to do that because the defect is big or it looks like Swiss cheese or there has abnormalities, but the majority of them can be treated without opening the chest. Mitral valve annuloplasty, where our patients who have rheumatic heart disease, we perform those operations at Washington Hospital, that the valve can be dilated. If the patient has already undergone aortic valve replacement or mitral valve replacement and they have abnormalities with the attachment of the valve and there is a leak around them, instead of going to the operating room and requiring yet a second operation, we can do those operations with the structural heart program. Any valve, both aortic valve and a mitral valve, can be also treated with a balloon. In about 2017, we were thinking about bringing transcatheter aortic valve to Washington Hospital. Our colleague, Dr. Mahadevan, who was at UCSF at the time, and myself, we were the co-director of the transcatheter aortic valve. Dr. Mahadevan is currently in Massachusetts, but Dr. Harsh Agrawal joined us as a full-time cardiothoracic surgeon now about 2 years ago. So these procedures, the idea is to treat severe aortic stenosis without, again, opening the chest in the hybrid room, or in our case, in our converted hybrid room. Closure of the left atrial appendage is an important part of our practice. Left atrial appendage is a site of clot formation and is a major cause of stroke in patients who have atrial fibrillation. One option would be to put the patients on a blood thinners and anticoagulation. Another option would be to close the appendage. Closing the appendage could be also surgical by us more invasively, or with the placement of a device which is known as Watchman from within the heart itself. Again, the patient can be discharged the same day, doesn't even need to stay overnight. Mitral valve clip is a new approach. I was a surgical primary investigator when the mitral valve clip was being investigated when I was at Stanford. And the first patient that had this procedure done was a 94-year-old woman who was a patient of mine. Now, Dr. Agrawal has started doing those procedures at Washington Hospital within the next 2 or 3 weeks. May I have this next slide, please? The idea of a transcatheter aortic valve, I described it before. This is sort of this picture depicts where the valve will end up in the aortic position. As you can see, the femoral arteries are a natural conduit to the aortic valve and allow us to deploy the valve in that position without putting the patient on a heart-lung machine or opening the aorta. At this point, the great majority of the patients, something like about 3/4 of the patients who have a calcific aortic stenosis are candidate for transcatheter aortic valve replacement. May I have the next slide, please? Watchman procedure, as I described, the left atrial appendage is a site of clot formation in patients who have atrial fibrillation. There are some patients who have bleeding when they're on anticoagulation. They don't tolerate anticoagulation, blood thinners really well. So those patients in general would do very well if you can close the appendage. Then they would stay on the anticoagulation for a short period of time, and then eventually they can stop it. Dr. Agrawal has started performing Watchman procedures at Washington Hospital for about a month and a half or 2 right now. He's very active. He can do 3 to 4 operations before the half the day is done. Why is that operation important for us surgeons? It also, when you're evaluating a patient for atrial fibrillation, they also may be found to have coronary artery disease or other structural heart disease or mitral valve disease. So this also may require surgery. In general, when you add these procedures to the armamentarium of your treatment, you also increase the volume of aortic cases. We have so far performed the 35 procedures for placement of a Watchman and anticipate to perform another 55. So probably in a year would be approximately 100 of these procedures will be performed at Washington Hospital. May I have the next slide, please? Mitral clip, as I discussed, some of the patients who have a mitral valve prolapse and they are older, and then we can reduce the degree of mitral regurgitation with a very low risk procedure through a puncture in the vein, not even the artery, by crossing the septum across the heart. We can grab the mitral valve and reduce the degree of mitral regurgitation. Dr. Agrawal is probably one of the most experienced people in mitral valve, mitral clip. He started that at UCSF when he was a fellow, and then subsequently did that at UCSF before he joined Washington Hospital. I believe our first case is about to start less than 2 weeks from now, about 2 weeks from now. This procedure is extremely low risk, very effective, and will allow the patient to go home the same day. And if they need additional procedures done, like a Watchman procedure, then we will be consulted for additional procedure. Or if the patient is not a good candidate for mitral valve clip, we can do mitral valve repair or replacement. May I have the next slide, please? As you can see, our TAVR outcome in 2023 and 2024 also, fortunately, has been outstanding. We have had no mortality, no significant cardiac events, and no acute kidney injuries, no disabling bleeding, and no device complications. And then we also have our patients to fill out a post-procedure questionnaire, and 100% of our patients have filled them out regarding how they feel after the procedure is done. It's very difficult to do a procedure better than that. This last year, we had 1 permanent pacemaker needed for one of our patients. Other than that, the patients have not even required a permanent pacemaker. So the past 2 years, our outcome has been outstanding. May I have the next slide, please? So what are our plans for the expansion of the structural heart program? Again, this is in collaboration with Dr. Harsh Agrawal, who's the medical director of our structural heart program on the cardiology side and a cardiologist. We are we already did, as Mr. Labossiere explained, that we did 100 TAVRs this year already. Since then, we have done 20 some more transcatheter aortic valve, and our hope is to do, approximately 30 or to 40 of them in the next 6 months. So I'm hoping within the course of 1 year, we'll do 60 to 70 TAVR procedures. About 230 to 250 patients are referred to our clinic for the TAVR procedures, and then more than 3/4 of them will end up getting the procedures. The Watchman program that was started in 2024 is expanding, and we anticipate to have approximately 100 of these procedures done in 1 year within about a year and a half. Mitral valve clip will start in the next couple of weeks, and that will have a significant effect on treating mitral valve procedure. By the way, at this point, it still is a little bit of an off-label use, but even tricuspid valve regurgitation could be treated with a mitral valve clip. Isn't approved, but basically an off-label use as far as the manufacturer is concerned for treatment of a tricuspid valve regurgitation. And also our plan is to bring a valve called the Evoke valve that can also be placed in the tricuspid position for patients who have a severe tricuspid regurgitation. We anticipate that our dedicated cardiovascular hybrid room will be open in 2026. That would be extremely important for us, so we can do open procedures alongside the transcatheter procedures in the same setting. That will also have an impact on treatment of aortic aneurysms and dissections, that we can treat those patients with open procedures as an emergency, and then concomitant procedures in the same setting in a hybrid room should they be necessary. This would be in par with the most advanced quaternary medical centers in the country that they perform these procedures in the cardiovascular hybrid. May I have the next slide, please? I'm sorry, this was my last slide, and I'll be happy to answer any questions.
Thank you, Dr. Beggy.
Thank you so much, and I'll be happy to answer any question. Otherwise, I will excuse myself for the rest of the board meeting, and I apologize if I took too long.
That's quite all right. It was very, very interesting. Thank you. Any questions for Dr. Beggy? Okay, well.
One comment I wanted to make, just in conjunction with this, just because of timing, but today we were notified by the American Heart Association that our Get With The Guidelines performance for 2024 for coronary artery disease as a STEMI receiving facility, we've exceeded the benchmark in every one of the measures for our Get With The Guidelines thing. So that was also great news.
One question I have, Larry, maybe it's to you. What percentage of patients for this structural heart procedures come from outside the district?
I honestly don't know, Doctor. Maybe Dr. Beggy knows.
Yeah, I know in general, I know that Ms. Nippin's questions in general, majority of our patients currently are referred to us by cardiologists who are in practice at Washington Hospital. If you go a little bit farther to the three city areas, that would be about 90% of our patients are referred from those areas. But I think we see evidence of expansion to other areas that are normally they would not refer to us, areas around Walnut Creek. Around the holidays, we had patients who came from Petaluma, both for open heart procedures and structural heart procedures. I would say at this point, 95% of our patients are coming from the East Bay all the way to the South Bay, and then a little bit to the east of us towards Walnut Creek. But also, Dr. Lee and I are very interested in bringing patients from San Francisco Bay Area, especially if they live in this area. And even if you see them at UCSF, would like to perform their operation here. It's easier for them and easier for their families to have their operations done here and get the exact same operation they would have gotten anywhere else anyway.
Thank you.
Thank you.
Thank you.
Great.
Thank you again for the invitation. I will leave at this time. Is that all right?
Thank you.
Thank you, Dr. Beggy.
Thank you very much, Larry.
Okay.
Yeah, next we have Dr. Saleh, who's going to do, I believe he's on for the medical staff reports.
Yes, he's on.
There he is.
Hello, everybody. I'm sorry if it's a little loud. I'm outside and raining. I hope you can hear me okay.
Yes.
We had our
Not now.
There you go.
You just, Dr. Saleh, you froze for a second, so maybe you can start over. There you go. So why don't you start now? Yeah.
Okay, so we had the general medical staff meeting yesterday, and we had some good updates from various presenters, including Ms. Park regarding construction. Kristen Ferguson gave us an update about a developing policy that we have and how to deal with ICE agents and that may come to the hospital looking for undocumented patients, and the hospital's commitment to take care of any patient of any walk of life that walks into our emergency room or our hospital that will be treated equally. We had an update on infectious disease by Dr. Martin. We also had an update from Dr. Killebrew about the upcoming elections. We have a lot of good nominations now for every position. They are being vetted by the committee that is handling that. But I think everybody, every position is going to be filled, and we're excited about the new slate of candidates that are coming in. And then regarding I had a printout of the census, but let me pull it up here because I don't have it with me right now, unfortunately. Where is Jaspreet? And I apologize. I'm on my children's school band concert right now. I apologize. Give me a second. Very sorry about that. Okay, I have my list. So we have 366 active members out of a total of 668. Of those, we have 2 administrative, 38 advanced practice providers, 99 ambulatory, 9 consulting, 11 courtesy, 141 provisional, 1 leave of absence, and 1 on temporary privileges. And I apologize for the very good report, but that is my report for today. Any questions?
Thank you, Dr.
Thank you.
Any questions? Okay, well, thank you very much and good evening.
Thank you. Have a good night.
Yeah, next we have the Service League report. Sheila Vijay.
Good evening, members of the district board. Again, a warm greetings from all the volunteers. I'm pleased to report that in February, 229 Service League volunteers contributed a total of 2,051 hours across various departments. The Service League held its annual meeting on February 18th. Volunteers appreciated the luncheon and thoughtful gifts. Attendees also enjoyed seeing some of our volunteers in vintage uniforms, a nostalgic and meaningful tribute to our past. The meeting featured a presentation by Mr. Donald Pipkin, Chief of Strategic Management at Washington Health, on rebranding. Following his talk, a vote was taken and the rebranding of the Service League passed by a majority. Going forward, we will be known as the Washington Health Service League. This is an important development and we look forward to implementing the next steps. At the meeting, Service League volunteers elected the following slate of officers for the 2025-26 term. In addition to continuing my role as president for a 3rd year, the new officers are Jill Simon, 1st Vice President, Valerie Walter, 2nd Vice President, Carissa Barberi, Treasurer, Marlene Yamura, Secretary, and Marina Bivanjari, Parliamentarian. I'm grateful to the Service League leaders who have stepped up to serve alongside me. I also want to take this opportunity to thank Kimberly and the district board for your support and trust in volunteers. My gratitude also goes out to every hospital team member who helps this place a welcoming and supportive place for all of us to volunteer. As part of our ongoing efforts to strengthen volunteer services, on February 27, Evangeline Aimana Iamura, Director of Volunteer Services, and I attended a mini conference in Fairfield hosted by California Association of Hospitals and Health Systems. Erica Frank, the Vice President and Legal Counsel of the California Hospital Association, spoke on key considerations for managing volunteers. The conference provided valuable strategies to enhance our program and an opportunity to exchange best practices with colleagues from other hospitals. We look forward to putting these insights into action. At that conference, I met Teresa Wilson, a volunteer from Adventist Hospital in Sonora. She chose Washington Health for her hip surgery based on a strong recommendation from a friend and made the long drive to receive care here with Dr. Sa. In all respects, she was impressed by the outstanding care she received. She sought me out at the conference to speak to me especially about our hospital. Lastly, earlier this month, Trauma Injury Prevention Coordinator Garrett Cordes and Trauma Performance Improvement Coordinator Ginger Miramontes began offering a Matter of Balance class to Service League members aged 60 and older. Designed to improve balance and prevent falls, the class has enrolled 12 volunteers. We look forward to continuing this important program and welcoming more participants in the future. That's it for my report. Please let me know if you have any questions.
Thank you. Thank you, Sheila. Any
Thank
questions?
you.
Have a good evening.
Okay, thank you, Sheila. Good evening. Thank you for your report.
Thank you.
Okay.
Next, we have Mary Beauron, our Chief Quality Officer. She is going to give the quality dashboard for quarter ending December 2024.
Great. Thank you, Kimberly. Good evening. So overall, we had a great quarter. Again, this covers data from October, November, and December. I'm happy to report that the majority of the metrics met or exceeded the goal. I'm going to start off with the infection prevention indicators with MRSA in the blood. So we've had some spikes with this, and it's sort of been a challenge, especially in 2024. As you can see, we had those 2 cases. And so we've been really working hard to get that back down to 0. And towards the end of 2024, we were able to do that. We had 0 infections. It's a very strict benchmark. So we're basically right a little bit lower than what they predicted with the way that they do it in CDC for NHSN. But what we've been doing to work on this metric is really making sure that we screen patients as they arrive in the ED to see if they have what's called colonized MRSA in their nose, meaning that they're at higher risk for that becoming an active infection while they're in the hospital, and then therefore maybe becoming active in their blood. So we've been screening to make sure that these patients can potentially move towards being decolonized, or we watch carefully. And hand hygiene, of course, is a big part of preventing the spread of hand hygiene of MRSA. And then we also are looking at interventions with patients that are at high risk, such as patients in critical care or patients that have central lines, getting what's called CHG baths every day. And that sort of helps keep the skin free of colonized infection that could be active and worse if it came into the patient's blood. So we did have 0 last quarter. I think a lot of the work that the nursing and multidisciplinary team is paying off with this, and we've actually been able to sustain that through this part of the year so far. But it's still on our radar. We've got to watch this closely. And then moving into catheter-associated urinary tract infections, we did not have any for the last quarter of 2024, which is less than what the CDC would predict for a hospital of our size and type. Again, this is a reflection of making sure that when a patient has to absolutely have a catheter, that we take care of it, that we look at it every single day and we say, do they really need this catheter still? If they don't, let's get it discontinued and removed. And if they do, we have to go through a very strict procedure of how we maintain the catheter so that the patient isn't put at risk for an infection. We've had, as you can see, there was times earlier in 2024 where this was an issue just with a couple cases. But we've done well even in the beginning of this year with not having any. It's been actually over about 240 days since we had a catheter, since this last one was in the middle of the summer. So another quarter of not having any and not having any calendar year to date. So that's great work on making sure that our catheters are taken care of. Then moving into central line associated bloodstream infections, otherwise known as CLABSI. I think everybody is always waiting to see what this metric is going to look like. Are we going to be able to sustain it with this phenomenal outcome we've had? And the answer is that yes, we have another quarter with no central line associated bloodstream infections. That puts us at over 2 years and 10 months. So we're really happy with this outcome. It's the result of a lot of hard work from multiple areas of the team. Again, this is if a patient needs a central line, of course they have to have one. We put it in and maintain it really well, making sure that it stays clean, the dressing is intact, and then of course when the patient no longer needs it, making sure it gets discontinued appropriately. A great reflection of a magnet hospital and how well that these lines are being taken care of. So good work, and I hope I can continue to report that next quarter. And then our surgical site infections, we've sustained some really good outcomes with high-risk infections such as colon surgery. You can see that we did not have any infections this quarter. We did have, just one bump mid-summer last year. And again, though, sustained really good outcome for patients that really need to be monitored for this as a high risk for getting infected. Great work in the OR, especially with the way that these cases are treated during the procedure and afterwards. We do follow these procedures for up to 30 days. And we're seeing a similar outcome with our surgical site infection rate with abdominal hysterectomy, another high-risk procedure for getting infected. And again, this is required on federal law that we watch this procedure very closely for patients developing a surgical site infection within 30 days of their procedure, and long sustained effort here of not having any surgical site infections, very similar to the same reasons that I mentioned before. So team working together really well to do that and doing a lot of good post-op education, et cetera. Very well sustained outcome. And then moving into C. diff, which of course is the very difficult spore to treat in patients that are on antibiotics. They're at higher risk for developing this spore infection. And so another outcome that we look at is to see how many patients have C. diff on their 4th day after being admitted to the hospital. We had 3 in this last quarter, far lower than what's expected for a hospital of our size and type, which would be closer to 10, almost 11 cases. So we've continued to sustain that for an extended period of time. And I think it's a reflection of this. C. diff can be transmission-based, so how are we doing on hand hygiene? When a patient comes in and they have an active C. diff infection, we get them isolated quickly, and then we do impeccable cleaning. The thing about C. diff is the spore can live outside for the body for quite a while, and so the cleaning that is done in each room is a very important part of this role. I think we have a phenomenal EVS team for doing that. All of our rooms are cleaned with a bleach or the equivalent, and that is really the only thing that takes away C. diff. In addition to that, when patients are showing symptoms of potentially having C. diff, we're very quick on getting the sample and isolating them. And then in addition to that, we're treating antibiotics very strictly. We have a great antimicrobial steward program here at the hospital. One of the outcomes of antimicrobial stewardship are your C. diff rate. So we're very careful and respectful of the antibiotics. We want to be able to use them as appropriately so that patients can have the best possible outcome from getting their IV antibiotics. We do also recognize that if we overuse antibiotics, you put yourself in increased risk for C. diff. So this isn't just a reflection of cleaning and testing and using algorithms good. It's also a reflection of great stewardship with the use of antibiotics. And then moving into our national patient safety goal with hand hygiene. I think everybody's aware that the best way to prevent the spread of infection is still hand hygiene. It's the best way to break the chain of how infection spreads. We have done a lot of work on this with increasing the denominator, the number of patients that we're observing to make sure healthcare workers are washing their hands before they go in to see that patient. We have a lot of observers in the hospital. We use an electronic monitoring system that has been very beneficial to us. So we have large numbers of observations, and we still, even with large numbers, have been able to show and demonstrate that we have high compliance. This is 98.9%. That even exceeds what Joint Commission expects, and Joint Commission goal is around 90%. And so it also exceeds what the World Health Organization expects, which is closer to 70, because that's how difficult it is to get people to wash their hands consistently. I think we've done a great job on here. This is not an initiative that you can ever really back off on. We all continue to work on it, continuous improvement, training new staff to observe, making sure the data is valid. And when people are seen, it doesn't matter what discipline, it's anybody who is an employee of the hospital and should have washed their hands at a certain time is monitored for this. And if we see any non-compliance, that person is approached in a very professional manner, mostly just to hear what made them think they shouldn't wash their hands. Were they interrupted? Did they not know this is a time you should wash your hands, etc. So we do what we call just-in-time coaching for this. So we are, of the few cases that we monitor where hand hygiene hasn't occurred, those healthcare workers get just-in-time coaching. And I think over the years that's really worked to our benefit, because we've been able to sustain this well into over 2.5 years now. And then moving into our nursing sensitive indicators, starting off with falls, fall with injury. So we have another quarter here where we have been below the anticipated goal. And so this is a reflection of actually one fall. We did have a fall for one patient in here. Every fall we take seriously. We do a root cause analysis on it. And we look at things like, was the patient close to the nursing station? Did they get rounded on enough? Because most of these people, and in this case, again, unfortunately, it's a very typical case. People are used to having their independence when they're at home. They come to the hospital. They're in a different environment. If you're elderly, which in this case, this patient was elderly, and they want to be able to just get up and go to the restroom on their own, and unfortunately fell, and as a result had an injury. So one of the things that we always look at, again, in addition to the things I also mentioned, is looking at, was the patient identified as a high fall risk coming in, because we do different interventions for those. And this patient was, and they were on the protocol, which is good, but unfortunately fell anyway. Again, though, far below the benchmark. We have had that spike very early, or I think it was actually mid 2024 where we went over the benchmark, but still very good. And the thing to remember about this last quarter is that this is where we started to see some of our uptick in our high census. I mean, of course, we have continued to see it in January and February, but this quarter does reflect, that last month in December. So if high census is going up and there's a lot going on, it's really important to stick to this process. And I think we've done that very well, monitoring patients for fall risk. Same thing applies with pressure ulcers, otherwise known as bed sores. This is a phenomenal outcome. This is zero. 0 patients were identified as having a stage 2, what we call a pressure ulcer, like I said, otherwise known to most people as a bed sore. So what happens with this process is we have a set of nurses that really understand what a pressure ulcer looks like. They know how to look for it, what to look for it. They do what's called point prevalence. They go around, they pick a day, and they look at random, and they pick patients and high-risk patients, et cetera. And they do a skin assessment in addition to what's already been done by the patient, already been done by the nurse when the patient's admitted. So, and if they find an ulcer, it goes in that day, and it's counted in the point prevalence study. And so to go, this many quarters, 3, without having any identified by experts looking at it is a reflection of making sure that patients are on the right type of bed. Patients are repositioned appropriately, following right nutrition when you can for patients, so they're at lower risk for developing bed sores. All of those things working together really lead to this outcome. And again, this is a nursing sensitive indicator. This is something that Magnet looks at very closely, and we are knocking it out of the park, so that's good. And then we're moving into readmissions. And so for readmissions overall, we've done okay. We have 2 out of the 6 that did not meet benchmark. And the first one is patients who had an AMI and then otherwise known as a heart attack and were admitted to the hospital within 30 days. And in this quarter, we had 3 of those cases. So out of 16 patients who came in with a heart attack, 3 of those patients came back within 30 days. And in this particular case, one of them did come back with some blood pressure issues, which you could argue is related. But the other 2 were not related to anything cardiac. But the way that the metric is set up by CMS, regardless of what you come back for and you get admitted for, it counts as a readmission. So I would say that of these 3, the one that we thought may have been preventable was that one with the blood pressure. So we went back and looked, and we had done calls with that patient because we call every patient who leaves this hospital gets a call within 3 to 5 days. And we try to get most of those calls done within 3 days of discharge because patients have a hard time remembering everything's going on in the hospital. And so we want to make sure that when they leave and they get calmed down and they're back at home, that they are really understanding what the discharge instructions were. So the one with the high BP, it's like, did he take his meds? You know, what happened? And what unfortunately happened in this case is we were not able to make connection through the phone call. We weren't able to reach them. We did follow up with the primary and got some feedback, and it does appear that the patient was taking the medication, but still, unfortunately for them, had blood pressure problems. So a couple lessons learned there, but it was higher than expected. And then when we move into pneumonia, which has typically over the years caused us some issues. It kind of goes up and down. This quarter, we had 3 patients come back with pneumonia, putting our rate at 11.1%. It is lower than what CMS expects, which is about 15.3%. However, we always look at all the patients and why they come back. I think most of you are familiar with Dr. Akawili. She has a phenomenal background in medicine and really understands pneumonia very well. She looks at all of our patients that come back and does an analysis on them, and she really goes deep into pneumonia because there are a lot of complexities with it. And all 3 of these were deemed to be unpreventable. That doesn't make any difference to CMS. They still count. But I think the news here is that they did have all the interventions and unfortunately still came back. The thing with these 3 patients is they were, I think we have, let's see, so there's 82, 83, and 77. So on the elderly side, chronic illness, one of them unfortunately has a terminal illness and was dealing with a lot of that, and so they're coming back. And one of our really big, strong values at Washington Hospital ever since readmissions program started is that we if the patient's leaning at all towards needing to be in here admitted, of course we do the full admission regardless. We don't try to put these people in different settings. We bring them into the acute care, we take care of them, and we learn what we realized could have maybe prevented it. And in this case, like I said, not very preventable. They needed to be in acute care. Then we move into heart failure. This is the one that I think is probably the biggest struggle for this quarter. 12 patients came back out of 49. So our readmission rate was 24.5. That is higher than what CMS would expect. They expect about 18% to come back in this case. So of these 12 patients, I looked at a lot of them. This is a very difficult chronic illness to manage, and there are multiple other comorbidities that typically go with these patients. Saw a lot of diabetes in these patients. They did get phone calls. We're really working hard to make sure that every single one of these patients, when they leave, they have a follow-up appointment. We want them to get in front of their primary care doctor within 3 days and at the very max 7 days, because when you have this type of chronic illness, it needs management that's very closely monitored, especially after going through an acute care admission. So in these cases, I would say that we learned that 4 of them possibly could benefit from palliative care. Palliative care is a process, getting families and patients to come to terms with using palliative care. But our transitional care team has been working closely. Palliative care team is very responsive to this and really trying to help us get more patients in there so that they can have a better quality of life and treat their symptoms, even though we know that we can't give them curative treatment. We want these patients comfortable at home with their families, not having to go back and forth to acute care, getting them the support of home health, and making sure they get to their physicians very quickly after discharge. So again, working on all those interventions, Dr. Akawili and Emmanuel, our transitional care nurse, is really helping with those. We know we need to get this addressed, and so we're doing multiple interventions for that. And then chronic obstructive pulmonary disease, another very difficult to treat chronic illness, very similar patterns that we see with CHF. So, but a little less. This just barely hit the benchmark. So we had 3 patients come back out of 17 that were originally here with their COPD diagnosis. So our readmission rate for this was 17.6%. It is just barely lower, but it is lower. We did meet the benchmark on this. We still take those 3 patients seriously, though. Dr. Akawili looks at all of them. She gives us feedback on what could we have done to manage them differently. Similar stuff, she talks a lot about palliative care. She's very passionate for palliative care programs because she understands the value that gives the patient in quality of life when they have chronic illness. So really working towards that. These patients actually did make it to their follow-up visit. And every patient in this category, I have one that's in their 60s, but the other 2 were over 75. So again, a difficult patient population to manage, and they did need acute care when they came back. And then moving into our surgical procedures, so cabbages, which we have a small volume on in this quarter. So we have one, and that patient did not come back in 30 days. And it is something that we've pretty much been able to sustain, of course, even with these sort of lower volumes. There is very specific criteria for how CMS puts you in this, because obviously we did more than one cabbage over that period of time. But there's a very specific type of cabbage procedure that falls into this category, the way that CMS does the metric. So I want to be clear that, of course, the hospital was doing more cabbages than that. But if you just look at cabbage on its own, inpatient, and they didn't have any of the exclusions or inclusions, they would end up on here. And so good news that the one patient didn't come back. I just want to be clear that it's not reflective of the overall number of cabbages that we do. They just fell into the algorithm according to the CMS data. And then moving into our other 2 procedures that we look at, first being an elective inpatient primary total hip, or patients coming in for their knees. There is a certain group of patients that do need to be inpatient. These are typically patients who are coming in to get a knee or hip replaced that have other comorbidities that make us think we want to keep them in the hospital overnight. We want to watch them. They need to be inpatient. So let's say that they have diabetes issues, or they have chronic pain after the surgery, or there's even some issues that are social issues sometimes where we know that they need the extra support to be home. So, to be in the hospital. So in that case, we had 25 of them that were inpatients, far less volume than what we do overall. 25 in the quarter, only 25 had to come in inpatient. And of those 25, 1 patient came back for something completely unrelated. It was a upper respiratory infection that had nothing to do with their procedure or any complication with their procedure. So, but the good news is that put us at a readmission rate of 4%. It takes nothing to get the percentage up when the volume is as low as 25. CMS knows that this is a higher risk group, and so they allow us to have about a 5% benchmark on this. So good job to the team there for it only being 1. And then on my next slide, we're going to move into it's important that you see our entire service line, right? So CMS only looks at the inpatient ones, but we want to show this group what happens to our outpatients. The majority of these knees and hips that are replaced are outpatient. That's where the standard is. We were far ahead of the curve on this. We were doing a lot more outpatient sooner because we have such a phenomenal program with our outcomes. But so it's important to see that the service line is much bigger than those 12 patients. So out of this quarter, we had 322 patients have their knees or hips replaced as an outpatient. Only one patient came back. That puts us far below the benchmark of what's expected. So we just had 0.3% come back. CMS is thinking more along the lines of about 5% come back, even as outpatient. And again, those are patients who are well, not anticipated to have a lot of complications, but still to only have one with that kind of volume is really great. These patients also, another thing to point out is even when they're outpatient, majority of these patients are not even going to a skilled nursing facility. The majority of these people are going home. They're going home with home health. They get a lot of support prior. The front loading, the education is a big part of what helps us with this. Phenomenal PT, OT services that are available. I think everybody knows that this is a very well-oiled machine in this service line. This is just another indicator that that validates that. And that is it for my report. I'm happy to answer questions. Thank you.
Well, thank you, Mary. Board members, do you have any questions? All right. Well, thank you for your report. Mary.
Thank you.
Okay, great.
Okay. We're going to move into the finance report.
Yes, we're going to, Ajay CL, our interim vice president and chief financial officer, is going to give the January report to begin with.
Thank you. This pulled up. What I would say is that the operating indicators, I know Kimberly went over them last month, but for a recap, most of our indicators for January were fairly green. Our inpatient census was up 2.6. Our combined average daily census was also up. Discharges were up nicely, 50. Patient days up 81 from budget. Observation days, although it says negative, that's a good thing because we want less of those. And our length of stay was positive, 2 from budget. Going on to the next page. Again, mostly all positive for January. Case mix index was better than budget. Deliveries higher, surgical cases higher. Cath labs were lower, and we'll talk about that on the next slide. Patient visits, emergency visits, all higher than budget. Next page, on the surgical cases, we were 25 over. Majority of the gain was coming out of the endoscopy procedures, 40 above budget. And on the cath lab cases, which were 28 below, as I noted earlier, 2 areas were negative: the peripheral vascular program and the cardiac cath program. Moving on onto our FTEs, the organization flexed really well. Productive FTEs were 168, 169, almost under budget. And the non-productive FTEs were a little higher, which is all in all not a bad thing. Total FTEs per adjusted occupied bed were better than budget at 5.44. This is the budget at 6.13. On the dollar side, I'll say that the results were a little mixed, and I'll get into that a little bit here. Our gross revenue, as you can imagine, with all the higher activity, was great. Almost $14.5 million over budget, $241 million. Our contractual allowances, however, which are a reflection of our payer mix and other things that are going on with our collection activities, those were below budget by $14 million roughly. And our bad debt and charity care was higher by about $2.8 million. So all of that then resulted in total deductions of $192 million versus budget of $175, which resulted in almost 79.5% contractual allowance deduction rate. against a budget of 77.2. This all then results in, if you go on to the next page, a reduction in our net operating revenue of 2.1 million below plan. So
Yes.
so the net operating revenue is about 2 million below plan. Operating expenses, good story. We actually did better than budget by $1 million. However, all of that then results in a net operating loss of 1.6 million against a budget of $500,000. And then the next side of it is the good story. We actually have a non-operating income of 6.9 million versus a budget of 2.7. Majority of it is coming from the foundation donation of 5.2 million. So you put it all together, and we had a net income of 5.25 million for the month against a budget of 2.2 million, 10.3% versus 4.1%. And on a year-to-date basis, our net income is 15.6 million against a budget of 8.7 million. So on a net income basis, we're doing great. Our operating income is falling a little behind plan. The next schedule here is the FASB basis, and the story doesn't change. It's directionally the same. Numbers are geography changes around a little bit. And the last slide here is the EBITDA margin. Our EBITDA was almost 2 million for the month against a budget of 2.9. And on a year-to-date basis, we are at 23.2 million versus a budget of 26.7. So that's my prepared report. Any questions? I'd be happy to.
Questions? Thank you, EJ.
All right, I will do the preliminary, report for February. I'm going to start with the total gross revenue trend. Patient gross revenue of 223.3 million for February was favorable to the budget of 219 million by 4.3 million or 2%, and higher than the February of 2024 by 19.2 million. Year to date, you can see that the revenue was favorable to the budget by 29 million and favorable to year to date by 181.5 or 11.3%. Moving on to the trauma cases, you can see trauma cases of 142 for February was favorable to the budget of 112 by 30 or 26.8%. It is quite a bit lower than what we've been seeing, so we did have what I think that everyone's calling a slower month, but it is still, as you can see, above budget.
Less days.
Exactly. You get it.
Yes. You'll see that throughout. There's only 28 days. We talked about this. There's 28 days in February.
Got it.
February had 28 cases less than January due to less days in February. Would you like to read the rest of the report? Average cases per day for February was 5, which is around the same number of cases for January year to date. Inpatient trauma cases of 45 for February were unfavorable to the budget of 73 by 28, and outpatient trauma cases of 97 for February were favorable to the budget of 39 by 58. Moving on to look at the trauma cases by activation code. Trauma cases for February, again, as mentioned, totaled 142, and the breakdown you can see is 10 Alpha, 35 Bravo, 97 Delta. Again, we continue to see the majority to be falls, followed by motor vehicle crashes, body injuries, medical symptoms, and then other. So the work that's being done out in the community on fall prevention is very important. Now, looking at our total gross revenue, it came in at 14.3 million for February, which was unfavorable to the budget of 14.5. So just slightly under the budget by 1.5%. February gross revenue, again, is lower than January due to 3 less days. that you can see. Inpatient trauma gross revenue of $9.2 million for February was unfavorable to the budget of $12.9 by $3.7 million, and outpatient gross revenue of $5.1 million for February was favorable to the budget of $1.6 million by 3.5. Going back to the inpatient gross revenue, came in at $134.7 million, which was favorable to the budget by 5.14 or 4%, and 10.9% higher than February of 2024. Looking at gross revenue, it came in at $88.6 million, was unfavorable to the budget by $0.82 million or 9.9%. So just slightly unfavorable, but $6 million or 7.2% higher than February of 2023. Average length of stay, we continue to see that below budget. It came in at 5.24, which was favorable to the budget of 5.30 by 1.1%, and was favorable versus February of 2024 by 5.3%. Inpatient average daily census came in at 188.6, was unfavorable to the budget of 188.8 by 0.2 or 0.1%, but again higher than February of 2024 average daily census of 166.2, about 22.4 equivalent days. Looking at our discharges trend, February discharges of 988 were unfavorable to the budget of 997 by 9 or 0.9%. Year-to-date, discharges were unfavorable to the budget by 2.4%. At this point in the month, we had 11 patients that had stayed over 30 days. Patient days trend, looking at patient days, it came in at 5,282, which was unfavorable to the budget of 5,286 by 4 days or 0.1%, but we're 9.6% favorable to February of 2024. There were 201 days for trauma patients, and so without the trauma, the patient days were also favorable to budget by 199 days or 4.1%. Looking at our surgical trend, total surgeries in February of 515 were unfavorable to the budget of 538 by 23 or 4.3%, but were 30 or 6.2% more than February of 2024. Inpatient surgeries of 244 were unfavorable to the budget by 24 or 9%. Outpatient surgeries of 271 were favorable to the budget by 1 or 0.4%. Looking at our surgical activity, we're looking at it a little bit different this time in terms of looking at more of the service lines. And so you can see, if you remember, our endo volume and then endovascular volume was all clumped in other, and now really separating it so you can see our GI cases and how that plays. So you can see overall orthopedics was up 8.7%. You can see there were 16 trauma cases. GI very close to budget. General surgery was down by 4 cases. Vascular was down by 19 cases. Neurosurgery by 6 cases. You can see urology by 6 cases. Cardiac was up by 3, and then other was down by 9. So just trying to get a better feel for the types of cases there. Moving on to cath lab, you can see that February cath lab cases of 188 were unfavorable to the budget by 17 or 8.3%, and was 1.6% less than February of 2024. Cath lab inpatient cases of 111 were unfavorable to the budget by 5.1%, and outpatient cases of 77 were unfavorable to the budget by 5.9%. Again, looking at the breakdown, you can see cardiac cases was down by 6 cases. Interventional radiology was up by 6 cases. Neuro IR continues to be going strong, and it was up by 4 cases. And vascular overall was down by 21 cases. Moving on to deliveries. Deliveries continue to be favorable to the budget. Had 126 deliveries, It was favorable by 10 or 8.6% to the budget, and were 3 more than February of 2024. As you can see, year-to-date deliveries were favorable to the budget by 8.5%. You can also see, I know C-section rate, we've been seeing that higher in the past. It did go down, and so C-sections as overall deliveries was 26.2% this month. We're working on it. There's not, as I know Terry and I spoke about, there's a lot of work that's being done. We can't necessarily all correlate it together. We'll probably see it go up and down as we continue to work on it. Non-emergency department outpatient trend, we saw outpatient visits of 8,444. They were unfavorable to the budget by 221 or 2.5%. We saw unfavorable for performance in February in terms of X-ray being down 8.5% and lab visits by 4.8%. And that they were offset by our infusion center being up close to 10%, cardiac rehab up 7.3%, and then also short stay unit up by 35%. So we need to see areas of growth in that. Emergency room visits, you can see that they came in at 5,113. We're unfavorable to the budget by 4.5%. But we're 4.6% more than the prior year. Year-to-date visits were unfavorable to the budget by 663, or just 1.5%. We did continue to see increases in more acute patients in terms of our level 6 critical patients, and also sort of that other level down one, level 4 too. So really, emergency room are seeing pretty sick patients that are coming through. Looking at our gross revenue recap, as you can see, surgical services were unfavorable to the budget by $1.9 million. As mentioned, cases were also unfavorable to the budget by 4.3%. Cath lab revenue was up 9%, favorable to the budget, but cases were unfavorable to the budget, so by 8.3%, and really that's the mix of the cases and seeing those increases in gross revenue for cath lab. Room and board was favorable to the budget by 0.5%. Birthing center was also favorable to the budget by 0.2%. Emergency department revenue, you can see, was 16.2% favorable to the budget, and as mentioned, that really has to do with the level of cases and the mix of cases that we're seeing through the emergency department. And lastly, ancillary services were up 2.5%, or $2.5 million too. Moving on to our payer mix, for February, government-sponsored payers made up 74.1% of the total gross revenue. This was favorable to the fiscal year 25 budget of 74.5%, and less than prior year's percentage of 77.2%. You can see that Medicare was right on budget, and Medi-Cal was slightly favorable to budget. As you can see, HMO was favorable to budget at 2.4%. PPO was unfavorable to budget at 20.3 by 0.7%. Our self-pay was up at 2.5, and then also TRICARE was very close, close to budget at 0.8. Sort of, it's the rounding piece there. So, yeah. In terms of our productivity indicators, productive FTEs were favorable to the flex budget by 86, or 5.5%, at 1,557 FTEs. We continue to flex in terms and seeing higher volume. Non-productive FTEs were unfavorable to the budget by 1, so very slightly at 0.9%, 163 FTEs. Overall, our total FTEs for February to flex were favorable to the flex budget by 84, or 4.9%. Our total FTEs per adjusted occupied bed came in at 5.50, which was favorable to the budget of 5.70 by 3.5%. Moving on to radiation oncology treatments, again, In terms of February, treatments came in at 337, with 5 cases, or 1.5% unfavorable to the budget of 342. If you go to the next page, you can see that in terms of looking at the number of new referrals, we did see 36 new referrals coming in from various sources, and also saw 25 new patients that were seen in our clinic. So continue to see, and I believe in January we saw a new radiation oncologist that started too, Dr. Victor Chen. Yes. Moving on to Washington Health Medical Group, clinic visits were under budget by 1.2%, and under February 2024 by 209. We did again have one less working day in February of 25 versus February of 24. Our primary care visits, including pediatrics, came under budget, primarily due to pediatrics being down, and also one of our providers in the State Street Clinic being out and having reduced hours. Our specialty care visits were over budget. Women's health was over budget by 244, and urology was also over budget by 114. Moving on to the Development Corporation, we saw outpatient visits of 2,055 that were favorable to the budget by 14 or 0.7% for February. Washington Outpatient Rehab Center visits were favorable to the budget by 57 or 3.9%. This was offset by Washington outpatient surgery cases that were unfavorable to the budget by 4%, and then Peninsula Surgery Center cases were also unfavorable to the budget by 23 or 22.3%. Looking at our key financial statistics, in terms of February, the days cash on hand did remain stable at 122 days compared to the previous month. But I do want to point out that Medicare had paused their payments during February, from February 18th to the 28th. And for that, it equated to about $5 to $6 million for us that we are now collecting, but we would have probably collected in February. So could have seen an additional 2 to 3 days in that. But we did remain constant at 122. And you can see charity care for the month of February was $224,000. Any questions for the month of February?
No questions.
All right, I'll move on to our operations report, and I'm going to start with our employee of the month. For March of 2025, it is my pleasure to introduce to all of you Priya Chokshi. She is the staff nurse 2 of intermediate care. Her connection with Washington Hospital began at an early age. She was actually born at Washington. Yay. She developed a sense of compassion that led her to volunteer at an Alzheimer's facility when she was in high school. That was when she realized that caring for others could be part of a very fulfilling career. Priya attended nursing school at San Jose State University, and in 2017, she joined our health system as part of our new grad program. Following the 6-month training program, she began working at 4 West. And then moved. Her colleagues made Priya feel welcomed, and learning from them for the next 4 years was a wonderful experience. Desiring a change, Priya decided to learn a specialty and accepted a role to be trained in the intermediate care unit. There, she joined a team where collaboration is fundamental. Priya says, quote, "This is a team that always helps one another. Without ever asking, someone will be there to answer any question or lend a hand." During the past 4 years, Priya has continued to learn and develop her nursing skills. But as her manager, Lisa Nueva, notes, it's Priya's compassion and emotional support that truly sets her apart. She knows that her patients and their families are at a vulnerable and sometimes frightening time. Priya pays attention to what patients say and how they interact with family members, trying to understand if they are feeling overwhelmed or have a specific question or concern that she can address. She notes, "I never want my patients to feel like I'm trying to hurry to the next room. I want them to know I will sit down with them, answer questions, or offer to contact their physician if needed. Before leaving the room, I try to ask, is there anything else I can do for you? Part of Priya's drive comes through an emergency cardiac event her father experienced. He was in Washington Hospital's ICU, and Priya saw firsthand how the care he received impacted her father's recovery. Afterwards, he told her that he remembered the name of every nurse who cared for him. The importance of the nurses and the care they provided always stayed with him. So that's made a big difference for her. Outside the hospital, Priya has many interests, including creative projects and spending time outdoors, hiking or rock climbing. Priya also likes to travel and recently thoroughly enjoyed a trip to Portugal. Congratulations, Priya, on being March Employee of the Month. All right. Moving on to the Washington Health calendar. We had a busy February, and bring it up. There you go. You can see, I'll just highlight a few of these in terms of we had staff that attended the Night to Shine First Aid Volunteers at Resonant Church in Fremont, 150 attendees. You can also see we had some community outreach at the Virtual American Business Women's Association, and Tammy Tyson and Christine Mickelson spoke there. And then also you can see that Washington hosted an education booth at the Union City Lions Club Crab Feed and did 30 blood pressure screenings there. So, I think it was before they ate, and we did ask that question. So. Moving on, as you can see, Mayor Gary Singh of Union City presented Washington Health with a proclamation honoring our partnership on heart health education at City Hall, and there were 50 attendees. Also want to note on February 26th, Dr. Saw presented new technology for robotic knee replacement and had 857 views on Facebook and YouTube. Moving on, do want to mention that our sports medicine athletic trainers attended and provided medical coverage for the Special Olympics basketball at Newark Memorial High School. There were 361 athletes and 155 teachers. And then again, our trauma team was out and busy and talking about Stop the Bleed education at the Union City Superhero Fun Run at Union City. Also, again, talking a little bit about fall prevention. March 5th, Garrett Cordes was doing some fall prevention training for our seniors at the Fremont Community Ambassador Program. Also, you can see that on March 11th, we hosted a health education booth at James Logan High School Job and Community Expo, and there were over 500 attendees there. I know there's one tonight that we'll see in terms of happening. Go through some of the pictures from these events. Here's the listing of the upcoming health promotion and community outreach events. We're continuing, our trauma team is out there doing Stop the Bleed training. You can see on March 19th. We also, on March 26th, have Dr. Chet Morrison giving a trauma program update on YouTube and Facebook. And also, again, being involved in Union City in terms of hosting a health education booth there. Moving on, again, there's our injury prevention coordinator is out talking about walking safety, Heart Smart Challenge Health Walk on April 1st. He's going to be involved in that. And again, on April 2nd, outreach team for trauma is talking about that Matter of Balance class, or giving one at Acacia Creek. Moving on, I do just want to talk for a minute about our employee recognition event that we had on February 22nd. We recognized all of the Washington Health team members celebrating a milestone anniversary with the health system. We had over 110 employees join us to receive their award in person. I do want to recognize two 40-year awardees that were there, Diana Haney, our pharmacy technician supervisor, and Kathy McCall, clinical lab scientist. Also, very special recognition was we awarded the Nancy Farber Patient First Ethic Award to Christine Mickelson, RN and Women's Center Coordinator. As a breast health navigator, Christine has made a profound difference in the lives of breast cancer patients. Christine's work ethic consistently exceeds expectations, and she demonstrates compassion and dedication to patients. And I just want to say again, congratulations to Christine on being the 2025 recipient of the Patient First Ethic Award. Then, just a reminder, May 12th is the golf tournament at Castlewood. Mark it on your calendar.
Okay, we need to move on to action items.
Yes.
All right, so the first action item is going to be a budget amendment for the More Time and Critical Care Pavilion infield project.
Yes, why don't I just get a little bit of background information on this action item. As mentioned, it's the infill project budget amendment. Just to remind everybody, Morris Hyman Critical Care Pavilion infill project consists of our new operating rooms that will be moving over to there. Also, we have our imaging center and our pharmacy, and then some support services also. At the board meeting on June 22nd, 2024, the board approved resolution number 1264, which was the budget for the Morris Hyman Critical Care Pavilion. And that budget that was approved was $87,464,729. And then at the meeting on August 14th, 2024, the board approved resolution 1266, best value contractor selection for the Morris Hyman Critical Care Pavilion. And subsequently, the board awarded the bid to Webcor Construction at $56,714,444. And they were the most responsible, best value bid for the infill project. As mentioned, this amount was higher than the construction budget that had been budgeted, which was approximately $52 million. It also included contingency. So this is when we said we would be coming back with this budget amendment. So as mentioned, the bid from Webcor Construction came in about $4.5 million over the board-approved budget, and then the need to add an additional $5 million was needed in terms of contingency for this infill project. We have been working to do about some value analysis in terms of identifying areas that we could reduce, and we did make some reductions of over $1.5 million. There are some additional areas that we needed to put some additional dollars in terms of cabling, fire alarm systems, and also project management for the equipment. So in total, I recommend that the Board of Directors approve the infill project budget amendment at the amount of $9,006,293.
Thank you. Do we have questions?
Mr. President, I move the recommended action.
Second. Thank you, Bill. Cheryl?
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Epen?
Aye.
Okay. We then move on to the consideration of the Chief Executive Officer's employment agreement. First, we must consider adjusting Ms. Hart's base salary. Second, we need to consider whether to give an incentive award for the fiscal year ending June 30th, 2024. And finally, we need to consider extending the term of the employment agreement. At this point, I'm going to ask Paul Kosarchenko to make his presentation.
Thank you, Mr. Wallace. It's been a while since Kimberly's Chief Executive Officer has had a review. So I'm going to provide the background information. Chief Executive Officer is the only employee of the district who is hired directly by the board. According to the CEO's employment agreement, the board reviews the CEO's performance annually on or before October of each year. Following the performance review, the board considers base salary adjustments and an award of incentive compensation up to 25% of base salary. Due to various reasons and with the concurrence of the CEO, the consideration of a base salary adjustment and incentive award was delayed until now. The district has a long-standing philosophy of wage parity for all employees, which includes the CEO. Wage parity means the CEO is not paid at the top, nor is she compensated towards the bottom of the scale. The district's compensation philosophy of marketplace parity establishes base salary for the CEO at around the 65th percentile of her peer group, with a maximum possible incentive award of 25% of base salary. Benchmarking executive compensation based on peer group data is a standard practice for establishing reasonable compensation for executives working for nonprofits. As in the past, Arthur J. Gallagher and Company was engaged to provide a report, the Gallagher Report, is what we refer to it here, for the board's use in deciding compensation adjustments for the CEO. Gallagher is a leading healthcare compensation consultant in the United States. Hundreds of healthcare systems use Gallagher services to satisfy internal revenue guidelines, regulations for determining the range of reasonable compensation. The Gallagher Report assesses the competitiveness of the cash compensation for the Chief Executive Officer. Appendix A of the Gallagher Report includes a list of similarly situated California organizations in the Gallagher's proprietary database. The Gallagher Report is included in the board's packet. Gallagher Report provides the board with appropriate comparability data in accordance with IRS regulations. In its report, Gallagher reviewed the background data on the district for the 2024 fiscal year. Gallagher then compiled data on compensation levels for California healthcare systems regressed for size using data from the Gallagher's proprietary database and salary surveys. Based on the foregoing, Gallagher prepared market charts summarizing compensation survey data at the 25th, 50th, 65th percentile for the California peer group. Charts prepared for both base salary and total compensation. For the prior board action, Ms. Hartz has been serving as the CEO of Washington Health since July 1, 2019. The board approved the employment agreement for Ms. Hartz at a board meeting on June 12, 2019. At that time, the board set Ms. Hartz's base salary at 80% of the 65th percentile in recognition that while Ms. Hartz had substantial experience and knowledge given her years of service as a senior associate administrator, she had not yet served as a CEO. The board set her base salary at that time at $712,000, which was 80% of the 65th percentile. On December 8, 2021, the board increased the CEO's base salary to $861,000, which was equal to the 50th percentile of the peer group. At that time, the board noted that it was incrementally adjusting the CEO's compensation toward the 65th percentile as she gained experience and as warranted by her performance. The board also decided to award Ms. Hartz $100,000 as an incentive award based on her exemplary performance. The board indicated that Ms. Hart's performance justified an award of 25% of her base salary. However, due to the impact of COVID-19 pandemic on the district finances, the board awarded $100,000 rather than the full 25% of the salary. On April 23, 2023, the board approved an increase in the CEO's base salary to $955,700. According to the Gallagher Report presented to the board, this adjustment aligned with 95% of the 65th percentile. At the time of the decision, the board acknowledged the CEO had successfully completed her third year in the role and demonstrated outstanding performance. In addition, given the CEO's performance, the board decided to award the CEO $120,000. The board noted that the CEO's performance merited contractual maximum of 25% of base salary, which would have equated to $212,250 but acknowledge the CEO's concerns about receiving the maximum award given the current and expected economic challenges the district would be facing in upcoming. As to the first action item, which is the base salary adjustment, the chart on page 13 of the Gallagher report, which is in your package and is posted on the website, shows that Mrs. Hart's current salary of $955,700 is compared to the peer group, the 25th, 50th, and 65th percentile. Current salary is 10% below the 65th percentile of $1,062,000. As previously noted, at the time Ms. Hartz was hired as a CEO, the board noted that Mrs. Hartz had not previously served as a CEO, therefore, notwithstanding the board's compensation philosophy to pay the CEO at the 65th percentile, the board decided to compensate the CEO at less than the 65th percentile while she gained experience and proved herself capable of performing the duties of a CEO of Washington Health. Since the CEO was hired on July 1, 2019, the board has steadily increased the CEO's base salary to eliminate the gap between her base salary and the 65th percentile. As of July 1, 2024, Ms. Hartz has served as Washington Health CEO for 5 years. Previous evaluations, the board has consistently rated Ms. Hart's performance as outstanding. As to the subject of the incentive compensation, Mrs. Hart's current employment agreement states that she is eligible to earn an incentive award of up to 25% of base salary. Page 17 of the Gallagher report shows that if the board chose to award the full 25% of base salary, the CEO's total compensation for the fiscal year would be at 11% below the 65th percent. Historically, the board has considered a number of factors in determining the amount of the incentive award portion of the CEO's compensation. These factors include consideration of various accomplishments during the past fiscal year. The board has received a separate report from the CEO, which includes a list of accomplishments for the board's consideration in determining an incentive award. Based on Mrs. Hart's current base salary, the board can decide to award an incentive compensation of between $0 and $238,925, which is 25% of the base salary. The last item for consideration for the board as part of this agenda item is the extension of the contract. In addition to reviewing cash compensation, the board typically agrees to extend the CEO's term of employment agreement to maintain a 4-year term. So, possible board actions tonight. In summary, the board should consider the following action items: a base salary adjustment based on performance and existing compensation philosophy. Number 2, an incentive award of up to 25% of base salary. And number 3, an extension of the term of the agreement. That is the end of my report.
I was wondering, yes, I'd like to say a few words before you move forward with the discussion. Also in your packet and on the website, you will find my annual report to the Board of Directors for fiscal year 24. This report outlines the significant progress we have made in advancing Washington Health's mission to provide exceptional, accessible, and personalized care for the health and well-being of our diverse community. We have done this through program and infrastructure growth and improving operational efficiency. We are striving to be your trusted and our community's trusted first choice for care. I believe you will agree that we have achieved meaningful milestones across the board. Notably, I want to highlight our successful designation as a trauma center. We are the first new trauma center designated in Alameda County in the past 20 years. The effort required to achieve this designation was monumental and a true all-hands-on-deck. I could not be prouder of our team across the entire health system, our physicians, our nurses, and our staff, who worked tirelessly to make sure this would happen and who are now saving lives in our community every day. We also strengthened our partnership with UCSF. We continue to grow our oncology-related services and started construction on the new UCSF Washington Cancer Center in order to be able to serve the increasing need for oncology services by our community. This means that cancer patients can receive local care without having to travel. My final point is that although I take pride in all of our achievements and steady progress in many areas, I recognize the financial challenges we continue to face. For fiscal year 24, we did not meet our hospital budget. However, On a consolidated audited basis, we significantly improved our financial performance over the previous fiscal year, generating EBITDA of over $17 million. I know that you will be considering a base salary adjustment and an incentive award this evening. After 5 years as your CEO, I leave it to your discretion as to whether or not I have fulfilled your expectations to merit the P65 level. As to the potential incentive award, we all are aware that the district continues to face ongoing financial challenges. Over the last 5 years, labor and drug costs have increased over 40%, while reimbursement for patient care from insurance companies and the government has not kept up with inflation nor with these costs. Considering these challenges, I ask that you defer consideration of the incentive award. Thank you.
Thank you, Kimberly. Thank you, Paul. As mentioned, the first issue for us to consider is whether to adjust Ms. Hart's base salary. The memo from legal counsel provides background information and includes Gallagher report with potential salary ranges based on comparable California peer hospitals. I will exercise the prerogative of the chair to give you my initial thoughts. When we hired Kimberly in June 2019, we set her base salary based on information from a previous Gallagher report. Gallagher provided peer information and indicated that the 65th percentile for base salary at the time was $890,000. As we all knew, the 65th percentile is our compensation philosophy target for the CEO's compensation. Gallagher report offered the following additional information. Depending on the candidate, Washington Hospital may wish to position base salary from 80% to 90% of the 65th percentile if the individual has limited experience as a comparable position or if she has recently been promoted and needs development time in the position. Typically, an organization with will position base salary close to the philosophy, 90 to 110%, if the individual is fully experienced, which means 4 to 6 years, and has demonstrated a record of consistently meeting performance expectations. With that in mind, the board set her base salary at 80% of the 65th percentile, which was $712,000. We did this because although Kimberly had many years of experience as an administrator, she did not have any experience as a chief executive officer. I expected, and I think all of the board expected, that as Kimberly gained experience and met our performance expectations, we would adjust her base salary in increments so that we could move closer to the 65th percentile. And that is consistent with our compensation philosophy and following the guidance of the Gallagher report. In December of 2021, we increased the CEO's salary to $861,000, equaling the 50th percentile at the time. We were following through with our initial intent of adjusting the CEO's salary incrementally to get closer to the 65th percentile as she gained experience and met performance expectations. The next time we reviewed the CEO's salary was on April 23rd, 2023, almost 2 years ago. We adjusted her base salary to be equal at the time to 95% of the 65th percentile, or $955,700. This was in keeping with our original intent of starting her salary below the 65th percentile as she gained experience with the intention of setting her compensation at 65th percentile after 5 years of experience and assuming that her performance warranted salary increases, and it did. Her performance was outstanding. Looking at the accomplishments for the 2023 and 2024 fiscal year and for the 2022-2023 fiscal year, I am truly amazed and impressed at what we have accomplished with Kimberly's leadership. While her memo to us speaks for itself, I want to highlight a few of the achievements. First, I am so grateful that we continue to expand our level of services. We are expanding our world-class cancer care through our continued growing affiliation with UCSF. Cancer diagnosis can be devastating, and the treatment can be both complex and difficult. How wonderful it is that we can offer the best cancer care available, world-class, to our community. Second, I want to commend Kimberly on her ability to significantly improve our financial picture. While we did not make budget, we did generate a positive EBITDA of $17.1 million. For those of you that are not familiar with EBITDA, that means that we had positive cash flow into our coffers of $17.1 million. This is especially noteworthy given continued pressure on reimbursement rates and significant cost increases associated with the Bay Area. Finally, and for me most importantly, was achieving our designation as a trauma center. This was no small accomplishment. Kimberly and her team deserve the highest praise. As a result, the trauma center has already saved dozens of lives that no doubt would have ended had those patients required transport to a distant trauma center. Whether you're already a patient of Washington Health or a Kaiser member, someone without insurance, trauma center is available to save your life or the lives of your loved ones. Kimberly has now been our CEO for 5 years. I have no hesitancy at all to say I'm in favor of adjusting her salary to the full 65th percentile or $1,062,000 even. She has earned it, and we are fortunate to have her as our CEO. Those are my thoughts. Now that I want to hear from my fellow board members on the base salary issue and on Kimberly's performance. Anyone?
Certainly. Mr. President, Kimberly has served us for 5 years in an outstanding fashion, and what a 5 years it has been.
Amen.
We've gone through COVID. We've gone through the economic repercussions of COVID, which have been an extraordinarily challenge. We've had to deal with the inflationary pressures on cost of drugs, cost of staff, all of those challenges. And even through all of that, we opened a trauma center, which has been a huge blessing to our patients. So I agree, Mr. President, that we should adjust Ms. Hart's salary to the P65 level. I think in looking at Paul's letter, the operative statement is her current salary is 10% below the 65th percentile. So we are not at present following our own compensation policy. I think we need to do that, and I think it's entirely appropriate to move up to the P65.
Thank you.
You have proven your leadership so extraordinarily well, not just in this room, but throughout the whole healthcare system. We've appreciated all that you've shouldered and the leadership that you've provided. You've done a great job.
As I sit here tonight and hear the numbers that Kimberly's been CEO for 5 years, I'm a little shocked. It's been quite the ride. It's also gone very, very quickly. And throughout that time, I've admired her leadership abilities and her way of working with the system in a way that has moved us forward. 5 years ago, there was almost an entirely different group here. And we've gone through that change very, very nicely and efficiently. Wonderful to have this group of people to work with, but it's most appreciative to have Kimberly. Thank you, Kimberly, and I very much support the motion that we've received tonight. Yeah, so, as detailed by the council and the president, I think pretty well explained. And, the goal was definitely to move to the 65th percentile. And it's been 5 years, like all my co-board members had explained. To me, I think one of the major things that I really appreciate is the feedback from the community. When you talk to people, what they think about the hospital and the accessibility and things like that. And personally, in my case, I think, it's been a very good interaction, a very mutual interaction, and I'm very glad to, work along with you, Kimberly. And no qualms about making it the base salary to 65%.
Thank you. I think that, in addition to what I've already said, I think it's apparent, the accomplishments, but I want to also thank you for not doing the things that could have got us in trouble.
A woman of integrity.
And I don't want to go through all of them, but part of success is avoiding problems, and that has been well done as well. I want to move on and open the discussion to the public. And is there anyone from the public who would like to speak on the issue of a base salary and adjustment for CEO? Okay, as there are no public comments, I close the public hearing. Are there any additional comments from any board members? All right, then.
Mr. President, I hereby move that the board increase the chief executive officer's base salary to $1,062,000, which is around the 65th percentile of the California peer group. And this adjustment shall be effective as of July 1st, 2024.
Thank you.
Second.
Thank you. Cheryl?
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Eapen?
Aye.
Thank you. The next issue for us to consider is whether to award Ms. Hart incentive compensation. Her employment agreement provides that we can make a discretionary award up to 25% of her base salary, or $238,925. In my view, Kimberly's accomplishment merit consideration of a significant award. However, I know that she has expressed some concern about an incentive award given the continued financial challenges facing the district. To that point, although we did generate a positive EBITDA of $17.1 million, we did not make budget, and system-wide we had a net loss, albeit we enjoyed a significant improvement over the prior fiscal year. So I am of two minds. On the one hand, I think we should reward Kimberly with an incentive award, but on the other hand, I want to be mindful of her concerns, and we have to be mindful of our financial results and future financial challenges. One last point before I ask for comments from my fellow board members, I want to say the following, which I believe that all of you will concur with. We are so fortunate to have a CEO who works so hard and is also willing to openly indicate that he is concerned about receiving an incentive award in light of the district's financial challenges. Just have to say that before we open our discussion. With that, please, may I have comments from my fellow board members. Thank you.
It takes a great deal of courage and integrity in the environment we live in, turn down an award like
that you've earned.
this. As our president has said, Kimberly deserves this, completely within guidelines from our Gallagher report. All the indicators from her work and for her accomplishments would say she deserves this. And then to come and say, no, my work isn't done yet. No, I don't want to upset the apple cart. I don't want to do anything that would cause difficulty. I think that takes a tremendous amount of courage, integrity. I admire Kimberly for willingness to do that. And, puts us in a difficult position. It really does.
Well said, well said.
Well, I agree with Dr. Stewart's comments. Kimberly has shown outstanding judgment over these years, and I would have to defer to her judgment on this matter, that we defer action on this item.
Thank you. Thank you. Anyone else? Okay, I will now open the public hearing on the subject of an incentive award. Does anyone from the public want to speak? Okay, we will then take no action, and we'll proceed to our item 3.
Mr. President, I hereby move that employment agreements be extended for 2 years for a new term beginning July 1st, 2024 and ending June 30th, 2028. And the President of the Board be authorized to execute an amendment to the employment agreement consistent with the actions taken here tonight.
That's a wonderful thing to second.
And third.
I'm anxious to do that, and I'm anxious to do whatever else.
Okay. All right, so.
Ready? Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Epen?
Aye.
I just want to say thank you. I very much appreciate all of your support. I could not do it without that support. But also, I truly have to say thank you to the executive team and the team around this table. It takes a team. It takes that collaboration. It takes that working together and that communication to be able to operate a health system to this, how large it is. And it takes an amazing team, and I have one. Mm-hmm. And I want to thank them. So thank you very much.
Yes, thank you all. Thank you. Are there any other announcements?
Nope, no other announcements.
Okay, well, this meeting is adjourned.
I know. Right on that.